We are live.
Hello, good evening, everyone. Welcome to iFocus Online, lecture number 559, module optics and refraction number 34 on the topic of magnifying loupe, lensometer, glare and contrast testing. Our moderator for the today's session, Dr. Pratiksha Sharma ma'am. She has done her MBBS from Lady Hardinge Medical College, followed by MS from Maulana Azad Medical College, Delhi. She has completed senior residency at Guru Nanak Eye Center, Delhi. Currently, she is associate consultant at Center for Sight, Haryana. Ma'am has done previously worked as specialist ophthalmology in ESI Hospital, Haryana. She is also recipient of Champions Award at YOSI, and she has multiple distinction in medical training and has authored over 30 journal articles and given over 40 publication lecture at various ophthalmic meeting, national and international. Welcome, ma'am.
Thank you, Shafi.
Our chairperson and second speaker for the today's session, Dr. Vijay K. Gotwal, ma'am, scientist and low vision aid Prasad at LVPEI Eye Institute, Hyderabad. She brings over 36 years of clinical and academic and research experience. Ma'am has done optometry from Elite School of Optometry and PhD from Queensland University of Technology, and has also doctoral fellowship at Flinders Medical Center. And she has been the first Indian to be awarded as Diplomate in Low Vision and Fellow of the American Academy of Optometry. She is also the founder of Meera and LB Deshpande Center for Sight Enhancement LVPI. Ma'am has trained more than 1,000 optometrists across India and has published 110 plus peer-reviewed papers and 160 plus presented national and international. And she is also a former president and International Society for Low Vision Research and Rehabilitation. Welcome, ma'am. Now coming to the speaker for the session, Mr. Vijay Kumar, sir. He is the head of optometry training program at LV Prasad Eye Institute. Sir has completed optometry from Bharati Vidyapeeth University, Pune. Sir holds dual master degree first in Masters in Health Services of Management from Griffith University, Australia, and bachelor's bachelor's in optometry from Chitkara University. Sir has vast experience teaching in UG and PG optometry students. Sir has expert in optometric instrumentation, optics of the eye, and occupational trainings. He is actively mentors clinical and research projects in optometry. Sir has presented research at multiple national and international conferences. He is also published in peer-reviewed journals on myopia, vision impairment. And Sir is currently pursuing PhD at City University of London and founder member of ALO. Welcome, sir.
Thank you, Shafi. Can I share my presentation?
Yes, sir.
Can you unshare it? Replace. I need.
Sir, I stopped my sharing.
I need to. Just can you confirm the slides are visible?
Yes, sir. Yes, sir.
And they're moving? Just I'll go.
Yes, sir.
Okay. Hey, thanks for the kind introduction and thank you for making part of this iFocus series. And let me thank my mentor, Dr. Vijay, who is sitting here, and I'm doing class in front of her, so it's been a long time. But thanks for this opportunity. So I will take you through the next 30 minutes, or maybe slightly beyond that, on a topic on Lensmeter. And the following that, Dr. Vijay will get through the contrast and the glare testing equipment. What do you expect from this class is that you will understand what are the commonly used operating principles of the Lensmeter, and we'll try to identify the key parts and its function. And I'll also give a very brief on how do you measure the vortex power and the prism power and optical center, and try to make axis marking for a spectacle dispensing. Ideally, this requires about 2-3 hours of classes on a face-to-face. Doing an online, this topic would be really challenging, but I made it simple that it will be easy to understand, follow the next 25 minutes of the class. The textbooks are the different names are given. So ideally, it's a focimeter. You are trying to find the focal length of the lens. So the focimeter and the Zeiss introduced when it introduced its name, it's the vortex refractionometer because you are trying to find the vortex and you are trying to find the refraction from there. And the Bosch and Lamb named it as a watermeter, and the American Optical Company named it as a lensometer. Ideally, you are supposed to call only this company manufactured lens meters as a lensometer, but it became a so common term, so generic term. Any lens meter made by any company, we call it a lensometer. So that's the similar example like your keratometry. The very simple, the meaning, you're trying to find the lens and you're trying to power the power of the lens. So that's where the term comes, lens meter. And in some textbooks, some commonly people also refer to as a lensometer. So both are interchangeable use. So it should not be issue when you use these two terms. I'll not get into too much of history, but the back then the lensometry concept started when the photography was introduced and started people trying to find the intensity of the rays. That's where it started. And the by 1876, Hermann Snellen introduced something similar to optical bench, may not be exactly optical bench, just similar to that. And by early 1900, we have something introduced by Tropman. The lensometers are there in the clinics, and the by late 20s, we have projection lensometers available in the ophthalmology clinics. Let me give a brief introduction to the what we are going to discuss next, maybe 20 minutes. So what we are trying to find the optical power of a lens. Okay. So, but commonly most of us knows the power means it's only one. Okay. But I've listed a couple of them. So this itself takes about half an hour lecture for to go through it, but I'll do it quickly. The power is denoted by different terms. The surface power, approximate power, equivalent power, effective power, and back and front vortex power. What the surface power is the shape of the lens. So can you see it's a +8 and the back surface is -4. Just it's the shape of the lens. Okay. What the approximate power is when a simple addition of the both front and back surface becomes the approximate power. You don't consider thickness, you don't consider the index of the lens because they play a major role, but we don't consider that's approximate power. Equivalent power is a bit of more theoretical concept, but let's say if I had to make it simple, imagine there's so many lenses together, okay? If I want to replace all the lenses by one single lens system, okay, I use the equivalent power. Because the multiple lenses are there, it's difficult to calculate the object size or image size from the which one to take reference plane, okay? What I can do is I can replace all these lenses by one single lens, that's called the equivalent power, okay? Effective power, we commonly use it, contact lenses. When you have spectacles and you want to move to contact lens spectacle. So that's effective power. And today what we are going to talk about more on a front and back vortex power. What this means is, let's say for example, let's say take this lens. If this is the back vortex, the back pole of the lens, from here, where is the secondary focal point? And from the front pole, where is the front focal point? That's the back and front vortex power. The reciprocal distance from the front focal point to the front vortex. Similarly, the reciprocal length, okay, from the back vortex to the back focal length. So that's what we are trying to measure with the lensometer. So the lensometer does not measure surface power, approximate power, equivalent power, effective power. It does measure only the front and back vortex power. The earlier machines, what we have devised as the optical bench, it's a very simple apparatus. Even still, people use it in the physical optics experiments. Very simple device. You have the target, that's can you say target here, and there's a projecting light, and you've got a screen. Okay, so in between you keep your test lens and see where you see the optimal focus from the lens to the screen. From the lens to screen where you get optimal or a fine focus image, that distance is the focal distance, and the reciprocal of that focal distance is the vortex power. So it's very commonly used in the past, and even still today we use it in the optics lab for the demonstrating power. The other technique what commonly use it, and even still people do it, and I've seen a couple of them, they do more accurate than the lensometer. So people who are very good at doing this. Okay. Hand utilization is, we know the lens properties, plus lens magnifies and the minus lens minifies, and you see the target movement. So using these properties, And since we have got the trial box with this, so without trial box you can't do it. Since we have got a trial box, what you can do is pick up from the lenses from the trial box. You can do the hand utilization. Okay, so if you have got an unknown lens is a minus, you pick up a plus lens. If your unknown lens is a plus lens, you pick up a minus lens. Okay, so put together as you see in the diagram and see the apparent motion of the target. So the lens which will neutralize the apparent motion. So opposite of that power is the lens power. For example, you required, let's say this is a plus lens, unknown lens, you want to test it, what the power of it, and you pick up from your trial lenses minus lenses. Let's say assume that at a -3, the motion becomes zero, apparent motion becomes zero. Since the -3 is the lens which is neutralizing, that means the unknown lens power is +3. So that's how the people do it. But I've seen a couple of my colleagues who does very accurate estimation of the astigmatism also. Uh, when you have the optical bench, when we have the hand nucleation, why do you need a lens meter? Very fancy equipment. The one of the issue with hand nucleation is the meniscus lenses. Okay, so if you look at the previous diagram, so the meniscus lenses have a difficulty in contouring to the back surface of the shape. Okay, so the hand nucleation can measure accurately front surface power, sorry, front vertex power, but not the back vertex power. If I want to place the lens at the back surface, it's difficult. You find a small gap. This gap can affect the optical performance of the lens. So it becomes difficult to measure the back vertex power. And the off late, the tests are become more precise. So maybe 100 years back or a century back, 0.5 error may not be significant, but these days even we are going to 0.12 dApts. Okay? So the precise equipments are coming and we are testing precisely so that you need a precise accurate measurement. The second is the backward X power. So the backward X power is becoming a standard to denote the power of the refractive error. So when someone says what's my refractive error +3 or -3, it's indicating that it's a backward X power, not the front vertex power. Okay. At a large powers, large thickness at a very high index, the backward X power and front vertex power may not be the same. So at a small powers, they are almost same, but at a large refractive errors, the back vertex and front vertex power may not be same. And as I told at the beginning, the mutilation of lenses, particularly meniscus lenses, if you want to find the back vertex power, it becomes very challenging. And of course, we don't have so much of time to give for hand nucleation. It takes some time. So Lensmeter is very quick and you get a quick measurement. So in the clinic, we don't want to waste time finding the hand nucleation. For multiple reasons, these optical bench and the hand nucleation is kind of replaced in the clinics. Most of the clinics, I don't see anyone doing hand nucleation these days by Lensmeter. Okay. And what you see here, the schematic diagram of the Lensmeter. So typically any equipment have got the two systems. Okay. One is projection system, the other one is observation system. Okay. So when you look at this, towards this, where I was pointing, this is consists the projection system, and where the upper part, this is the observation system or a viewing system. Okay. In simple, your light source, your target, okay, this is part of the projection system, and your standard lens, okay, and your unknown lens. And when you don't have unknown lens, if the target is placed at the focal length of the standard lens, the rays coming out of this lens would be parallel. You will see a clear image. Okay. The moment you place any unknown lens based on the plus or minus, depending on the vergence it brings, the target will be blurred. So to make the target clear, what you do is, can you see there's a dial? That's the lens dial or the power dial is connected to the target. You move front and back, till the image gets clear. So that's in short. And when it comes to observation system, we have got a telescope. Primary function of the telescope is just to magnify the image. Okay, but there is no other function about telescope here. So it just magnifies the image. And within the observation system, you have got a protractor also there. There is also reticulus there. Okay. In addition to the target, what you see is the some people look at the inside the protractor to measure the axis. It's fine. Some people do the external device. I'll show you in the next subsequent slide. In the external device also you can find the axis mark. It's up to you. Okay. However, there's a concentric circles, rings. These will define the prismatic power, and I will discuss in subsequent slides about when we come to the prism power. This is a schematic view. If the previous image was short, but if someone want to clearly look at it, that there's a light source, there's a target, there's a standard lens, unknown lens, and if unknown lens is not there, you see a clear image. When you place unknown lens, the target becomes blur, and you move front and back to make the image clear. So that's the precise about the Lensmeter. It's the same. When it comes to operating principle, there is a two types. One is Badal and the other is non-Badal. Okay. So what we commonly use today is a Badal type. So, but to understand better what the current optical principles of the Lensmeter, I'll quickly go through the non-Badal type. Then you will understand why we have the current model of a current Badal type of optometers or lens meters in the clinics. The fundamental difference between these two types. Okay. So, uh, the target will be there, the standard lens will be there, and the telescope is there. It's a common. Okay. The fundamental difference is the distance between the standard lens and the unknown lens. That means, I guess most of you have done the lensometer. When you're placing the lensometer on the lens top, okay. So that's what I'm talking about, unknown lens. That's the lens top. The distance between these two is almost each other. So they're close to each other. Okay. In a non-Badal type, they're close to each other. So they are not separated. So they are close to each other. So that's the major difference. Okay. Whereas in Badal type, there's a difference. There's a distance between these two. What the distance we'll discuss later. That's a major difference. Okay. Having this setup, okay. When it is unknown lens is close to standard lens, it has got some demerits. Okay. What the demerits are, if you look at the diagram, a couple of things. Okay. One is, if you use a plus lens, okay, if you use a plus lens on the lensometer, the scale becomes compressed. The scale becomes compressed. What that meaning? For a plus lenses, you move the target very little. So the scale is very close to each other. When you use a minus lenses, okay, the scale is very wide open. The scale is widely open. What that meaning is, when you got a plus 5, when you got a minus 5, the target movement is not same. The target movement is not same. So that's one of the disadvantage with the non-Badal type. For a plus 5, I move some X amount. For a minus 5, I move X plus amount. So the amount of the target movement is not linear to the power of the lens. That's the major problem. Okay. The reason is these two lenses acts like additive lens. For example, let me give you. When I got a 20 dap lens, okay, and if I place a minus 10, what happens? Now the resultant power is plus 10. The resultant power is plus 10. Okay. Now the target moves from there. You need to calculate. So how much you need to move. So that differs when I place a minus 10. Okay. And similarly, when I got a minus 20 lens, can you guys where it goes? Because you got a plus 20 lens here and you're placing a minus 20. Now the target has to go to infinity. Is it possible? It's impossible. Okay. So that's the demerits of the non-Badal type. So one is the target movement is not linear to the power of the lens. For a plus lens, for a minus lens, you move differently. Let me give you example one more time. Okay. Standard lens power is plus 20. If I have a plus 20 diopter lens, now what is the total power? It's a 40. Okay. 40 diopter requires about 2.5 centimeter movement. But if I replace the plus 20 with a minus 20, can you see? Image will go to infinity. For a plus 20, I'm making a 2.5 movement. For a minus 20, I'm making the target go to infinity. So that's the linearity is not there. Okay. And the second is for a minus lens of same power. Okay. That's a limitation. If I use a minus 20 or whatever the standard lens power, if the standard lens power is 25, 30, whatever the power, I can only measure up to that power. Moment if the standard lens power is 25, if I use a minus 25, the target has to go to infinity. It's impossible. Okay. So these are the limitations of the previous generation or the non-Badal type of the Lensmeter. Okay. It's here, it is there. So positive lenses, the target Meyer position is very close to standard lens, and the minus lenses, it goes very far, and the target movement is unrelated to spectacle power. I gave example plus 20 and minus 20. Okay. Plus 20, you are moving only 2.5 centimeter, minus 20, you are moving to infinity. Okay. And minus powers are measured only up to the standard lens power only. You cannot measure beyond that. Okay. And the Since the plus lenses act like additive lens system, the plus lens produce some kind of a Meyer magnification, and this magnification also has some limitations in measuring the lens power. So too much of magnified image also will give some bias in measuring the power. What the current lensometers, okay, Badal type, okay. So what we have shown in the beginning of the presentation, that's a Badal type. Can you see clearly the distance between the starter lens and the unknown lens? Whereas in Badal, non-Badal type, they are very close to each other. They are very close to each other. Unknown lens and the standard lens. But whereas in Badal type, there is specific distance. Okay, there is specific distance. This distance is equal to focal length of the standard lens. This simple change, okay, this single change makes the optical performance of the lensometer is unique to it. Okay, so what is the difference? Unknown lens is not close to the standard lens. Now it is at the focal length of the standard lens. So for example, if the standard lens is 25 diopters, the distance between the unknown lens to the lens is about 4 centimeters. If the standard lens is about 20, it's about 5 centimeters. So that's the distance you are looking. By placing this, whatever the deficiencies we listed here, okay, what you've seen here, all will be disappeared just like that. It's like a magic. Okay, just changing the position of the unknown lens power placement makes these deficiencies be overcome very quickly. This example I'm showing. So standard lens power, there is a f1, that's a primary focal point. At a primary focal point, we are keeping unknown lens. At a secondary focal point, you've got a target. So this target is similar like what we discussed. Now, what is a change is happening? Okay, so previous it is acting like a additive system. So when you bring the two things together, it is acting like a additive system. Okay, but when the previous arrangement just now I discussed, by placing the standard lens, unknown lens equal to a focal length distance, it does not become additive lens system. It becomes a thick lens device. It becomes a thick lens device. Whereas previously, it is additive lens system. Sometimes it is becoming a neutralizing type device. If I have plus 20 and minus 20, it becomes 0. Now I need to go to infinity. Okay. So that does not happen in this system. So it's actually like a thick lens device. Okay. So what happens with this search? The couple of things. One, since when you use a plus lens or minus lens, the Meyer magnification will not change. So the Meyer magnification remains same irrespective of the lens power, irrespective of whether you put a plus lens or a minus lens, it remains same. Okay. And I also discussed the target movement. Okay. For a plus lens, minus lens, you move the same amount. Okay. If you put a plus 5, if you move X amount, for a minus 5 also you move X amount in opposite direction. Okay. That's the uniform scale you get. Since you got a uniform scale, the lensometer is not bulky. Okay. If you use a Badal type, non-Badal type, you should have a very bulky instrument because sometimes the target has to go to infinity. It's impossible to make that lensometer. Okay. Badal type, the lensometer becomes office equipment kind of thing because you make it very small device and the scale is uniform for plus lens, minus lenses, and definitely for minus lenses, if you put a minus 20, you don't need to go to infinity. You just go a couple of millimeters back, you'll able to measure it. So why this happens is very simple. I guess hope you're seeing this. Yeah. So I told at the beginning of the presentation equivalent power. So I'll not get into the details of it, but very simple. When you place the unknown lens and the standard lens, okay, and they're separated by a distance equal to the standard lens power. That's the focal length. Okay. What happens at this place is when you do this, the equivalent power of these two lenses, okay, when you place a plus lens or a minus lens, okay, in both the conditions, the equivalent power of the combined system is equal to standard lens power. So what that meaning is, can you look at the down? So don't go with the equation. So at unknown lens, I got a plus 5 once. At unknown lens, I got a minus 5 once. This is a standard lens power, very simple calculations, okay. And the resultant power is plus 20. Resultant power is plus 20. What that meaning is, on the lensometer, whatever the power you place it, the combined system of the lensmeter is always acts like a 20 diopters. If a standard lens power is 25, it may be 25. If it is 30, it may be 30 diopters. Okay. So that's where whichever the lens you place it, okay, you're always viewing through a standard lens power of 20 diopters. So the Myers will not change. The Myers will not change. Okay. And the target moment is, I'll not get into this too much, but the principal planes, the planes where the maximum refraction happens. Now the target moment is linear to the principal plane location. So what happens is the principal planes, though the power is same in the both the cases, okay, the principal planes will shift. The principal planes will not remain same because though the power is same, but can you see there is a one time there is a plus 5 is acting, other time minus 5 is acting. The principal planes will shift linearly. Okay. So this linear shift in the principal planes will make the target moment is linear to the lens power. Okay. So you could also find the target moment also we can calculate in the classrooms, but that's way beyond for this class now. But that's how the lensometer operates. So when you go next time, what you see is put a -5 or a -10, +10, whatever the lens. You don't see any change in the Meyer size. It's just because of the what we discussed just now. We can also find the target moment. How do we find the target moment is with the equation, but the very simple. If you know the standard lens power, let's say if it is 20 diopters, I know the 20 diopters focal length and the focal length square in meters and the power of the lens you want to measure it. That will decide the target moment. So it's we can use the extra focal distances using the Newton equation. We can find the how much you move the target for a one diopter. For example, if you have a 25 diopters lens and the focal length is about 4 centimeters, nothing but about 0.4 meters. Okay, square of 0.4 it becomes 0.016, and if you got a lens power of 1, and it approximately comes around, if you got 25 diopter lens, for every 1 diopter you move around 1.6 millimeters the target, either front or back depending on the lens power. These are the different controls on the lens meter, but the common one you should know is the eyepiece, and there's the lens holder, and there's a lens table or lens stop, the power drum, and the axis wheel. So this is what I was indicating at the beginning. So someone will look at the inside the protractor. So someone may look at the outside the protractor. So it's either fine. Both will give the same. I prefer outside because it gives a more precise value to me compared to inside. There could be some misalignment of the mites. I'll not be able to accurately guess the axis. So I usually look at the external axis marking. Coming to the eyepiece, it's I got a +5 to -5, some of them +6 to -6. So before you make any measurements, always do the eyepiece focusing. So do anti-clockwise and clockwise rotate. So while looking at the target inside, so when you anti-clockwise rotate it, it becomes blur. And whenever it becomes first clear, then stop it. That becomes eyepiece is focus. So when you don't have eyepiece in focus, you may get a gross errors when you measure the lens power. The chrome knurl sleeve, again, some of these current generation lensometers, I'm not seeing this, but the older ones have it. So where, can you see this one? Yeah, this silver color one. So this is rotatable. When you rotate it, so the graticule, inside the graticule can rotate it. It can rotate it. The advantage is, so let's say if you want to find the axis, can you see? So you'll have difficulty in finding what axis it's, okay? You can rotate it exactly, you can read from the center. So that's one advantage you can have it. And also when you rotate it, the graticule also moves. Can you see? This is for the measuring prism. So each circle corresponds to one prism diopter. 1, 2, 3, 4, 5 prism diopter. It maximum measures 5 prism diopters. But with the small changes, you can measure twice the 5 prism diopters also. So you can you can measure up to 10 prism diopters, the small change. You can also do the axis marking, which is very rarely, again, the current generation of lensometers, I don't see it. But once you find the optical center, you can also mark with this 3-pin at the center. So you can also do the axis marking. This will be typically useful for the dispensers who want to dispense the lenses. Okay? So they can axis mark and they can mark the lens where to fit it, and they can make into your desired spectacle frame. So I will discuss this at the end of the slide. You got a power drum and you got an axis wheel. The axis wheel, I use it outside one because you can exactly locate it and it's a magnified view. Inside, also you
Vijay,
can locate it, I don't see, but the
Vijay,
small challenge.
Vijay, excuse me.
Yes, Vijay.
You're finishing, no?
I should finish in 5 minutes.
Okay, okay.
Yeah.
That's it. Fine.
So the targets are the two types. You got a cross or you got a starburst. Either way, use it. So commonly use the cross one. The cross one, it's a relatively advantage, but the starburst also commonly used. It's up to you. The coming to the procedure, it's very simple. So make sure the crossbar at the center and the power drum at 0 and the focus the reticule that the IP is focusing and place the lens on the lens stop like so the concave side on the back side, that means we are measuring the back surface power, so back vertex power. And if it is spherical power, so all the mirrors will come to sharp focus at once. So that's the indicates spherical power. When you have this is the example of spherical power. So you get all the mirrors sharply focused at once. When you got a cylinder, so you see this disturbing pattern. So you don't see the both, and sometimes if it is not aligned, you see a break also. So then you rotate the axis wheel to make it align, and then you start measuring the power. Okay. Very simple. If someone, when I was doing it, I used to get confused how to measure the power, but it's very simple. So when you're using the cross mire, the focus always thin mites. It's very simple. Then measure the focus second thick mites. The difference is the cylinder. So thin mites, thick mites. The difference is the cylinder. And axis is whatever on the outside wheel you see, that's axis. So it's very simple measurement. Okay. So some people get difficulty in doing so, but it's you practice it, so it's easy to do it. So this is how we measure the back vertex power, and very rarely we measure the front vertex power. You need to reverse the frame. So you need to reverse where the front surface should focus the lens stop, but which is not done routinely, but people also do it. The prism, let me do it quickly. So at the beginning, make sure the mires are like this at the center of the central circle. And what you do on the lensometer, assume geometric center of your spectacle lens. Okay, place it on the lens stop. If they don't change, they remain same. Okay, they remain same means your assumed geometrical center has got optical center. No need to worry. So that's the spectacle lens is fine. Okay. Now, when you assume geometric center, when you put it on the lens stop, you see like this. Okay, they are not in the center. That means it has got some decentration. It has got a prism. That means the mires are not in the center. Okay, it has a decentered. Now it's two options. Okay, when you move the lens, on the lens mid stop, if they come to the center, okay, if they come to the center means it's a decentered lens. It is a decentered lens. Okay. If you move the lensometer on the lensmeter, the lens, if you are moving, the mires will never come to the center. That means it's got a ground in prism. That means prism is made onto the lens. Okay, that's how you can differentiate it. You can also find the prism power using these concentric circles. Let's say I'll give you example what the power is. It's not a it's oblique prism power, but I'm just giving it's about 2 prism diopters. We can also find whether it is a base orientation also based on the spectacle frame when you're placing out in the lens meter. For example, if on this lens you're measuring and the mires move towards left, so you know that's base out. On the lens, if the mires move towards inside, it's a base in. Up and down you can do it. And similarly, you can also locate the oblique prisms. So again, once you get oblique prism, you need to do the compounding prisms to the resolving prism. That's it out of the discussion now. The last one is axis marking is you get a lens like this any manufacturer, and if you want to find the axis this is cylindrical lens. Okay, this does not have axis now, so it's not a particular axis, it has got astigmatism. Okay, so I cannot say it's 90 or 180. Okay, so when it comes to spectacle lens, it has got axis. So before it comes to spectacle lens, I can place it to any patient. So 90 I can use it, 120, 130, the power, if it is 1 minus 1, I can use it for any patient. Okay, so what the dispenser will do it in his clinic or in his the dispensing unit, he focus the prism, sorry, focus the cylinder. Okay, once he focus the cylinder, what he does is it's 90, but let's say I don't need 90, so I need it 120 or 15, whatever it is. Okay, I just simply rotate it. I simply rotate it. Okay. While I rotating, I also change my cross wheel. So the axis wheel, because I need to change the axis wheel. Okay. So when it is 15 or it may be 20, whatever it is. Okay. When it is like this. Okay. So I want to place this lens onto the trial or onto the patient's lens. Okay. Now what I do is I'll fix the lens like this. Then use the axis marking. Can you see the device? I will punch here. I will punch with that. Okay. So now it will be 3 lines will be there. So once the 3 line comes, I'll bring it out. I'll connect a line like this. I'll just the 3 dots, I'll connect it. I'll give it to the dispenser. What it does on the frame, he aligned this with the geometrical center of the frame. It's very simple. So we don't routinely do it. We get complicated, but it's a routinely done procedure. It's not a very complicated to learn it. Okay. The source of error are multiple, but the one is the eyepiece focus and the accurate placement of the lens stop. Okay. And the calibration at power 0 setting, you do the eyepiece and focus and you're able to get it. And very rarely, if you have got a precision lenses of known power, you can also use to calibrate the lensometer, but usually we don't do it, we go for a biomedical help. These are the ANSI standards. I guess you refer to the power. And higher powers, you should be more careful compared to your lower powers. The magnifying loupe, which I'll take 2 minutes, then so this is a bit of I think outdated concept. Once the slit lamps are into multiple magnification devices are there, but it's a single lens device. It's a positive lens. We have used at the childhood. We used to use handheld magnifiers. It's simple like that, but not. So what you use it? Use a plus lens and a magnifying lens. It acts like a magnifying lens, and the very simple the logic is you bring the target within the focal length of it. It makes a virtual image. So if this is the target, and if you bring the target within your focal point, can you see this is the focal point? Now the target is within the focal point. Now it makes a virtual image. This virtual image is magnified, and it's also erect. It's also erect. Since it's not reverse, you don't get any confusion. Okay. The disadvantage with the magnification loupes are you need a external illumination. So because it only provides magnification, you don't have any illumination. So typically you get about 2x to 8x, and the biggest advantage you got upright image, no orientation issues, you can use it. With this, I'll stop. Any questions, I'll take it later. I know it's Vijay is waiting for their session to finish, and I'll stop it here. Thank you so much for patient listening.
Thank you, Vijay. Wonderful.
Yeah.
Very nice. I learned so much.
Thank
Now,
you.
if you
I'll just stop sharing. You can share.
so let me see if I can share then. Let me see. Tell me if it is visible.
Yeah,
or not.
I'll.
Just 1 second. Now, where is mine?
Did you open the presentation already?
Yeah.
Yeah, then. Yes. Can you go to presentation mode and?
Now it is in presentation mode.
Yeah, done. It's there.
Okay. So we'll switch gears now, and I will take you through what is glare and contrast sensitivity. I'll see how much time I have, first of all. Okay. So in the remaining 20 minutes, we'll see the importance of glare and contrast sensitivity. So I'm Vijay Kumar, and I'm at the LVPEI Eye Institute. So what is glare? All of us experience glare, right? It is unpleasant light, and but there is a big variation, and it's so subjective. You can have, and it's more bothersome, especially when it is near the visual axis. And glare occurs when the brightness is more than the background. There are different types of glare. The most important is disability glare. As you can see on this on these two pictures here, you see the left picture. This is a driveway which is a clear, sunny, clear sky. But on the right side, this is daytime. On the right side, you can see all that. In the night, you can see all those starbursts, those issues that occur with oncoming headlights, right? So that is that kind of disability glare. So there is reduction in the visual acuity by light, which is elsewhere in the field of vision. And because of the intraocular light scatter, it is stray light. And actually, this is what is representative of a patient's actual visual impairment. And in addition to so glare occurs when there is a disturbing light source. When you take off the light source, there is no glare. So then that is called photophobia. And so in addition to the bright light source, what are the other causes of glare? There's lens fluorescence, because lens is responsible for absorbing the UV and it emits the visible spectrum, senile miosis. So you often see glare more often in the older adults. And then people who undergone cataract surgery, right? Very common. Dysphotopsia is what they would say. And then ocular media disturbances and all of that. Then you have specular reflection glare. You can see from the snow fields, roadways, right? Again, that is annoying. Now you have something called adaptation glare. So you go to a movie hall, you come out, and that is called, for 2 seconds you can't see, right? Because you're adapting, your retina is adapting to that kind of light sensitivity or the darkness. So that is, then you have discomfort glare. Now discomfort glare is more of photo aversion. You can see this child, right? This child is a child of primary congenital glaucoma. Now this is photo aversion. You have these children, they'll bury their head in the pillow. They will not raise their head, all of that. And like I already said, you have dysphotopsia, which is unwanted light images, post-cataract surgery. Most patients will complain. And you have both positive and negative dysphotopsias. Now, there's a subtle difference now between photophobia and that glare. Now, photophobia is, again, abnormal intolerance to the visual perception of light. And the primary causes you can have, it can be CNS related, it can be in the eye, but there has to be a definite organic base. Now, you can have iritis, you can have corneal aberrations like that Harp striae that I showed in that congenital glaucoma, right? And you can have irritation of the trigeminal nerve. You can have posterior segment disease like cone dystrophies, rod monochromatism. Migraine, again, it is one of the causes of this photophobia. And you can see this. And what do you do? So these patients who have severe photophobia, they'll have their sprain in the neck. So they'll never be able to raise their head. They'll always bend their head down because they're not able to raise their head. And tense facial muscles, they are squinting. They'll have something like hemerotopia, their day blindness, they are not independently mobile outdoors during the daytime. And simple interventions, like you can see this child, see how the child is squeezing, on the left. On your right, you see, the moment you put a filter, right, one of those no infrared filters, you can see the child smiling immediately. Or you can have, the child can use a peak cap, they can use a visor, anything that reduces the amount of light that is. So why bother? Why should we measure glare? Why should we know about it? That is because it's been shown in the literature that the visual acuity in people with visual impairment, especially mild vision impairment, right? It's a poor predictor of their problems with everyday activities. So there are people sitting in the clinic right in front of you going on complaining about problems with daily activities, maybe reading, maybe watching television. So this is because of the disability glare. Maybe the paper that they're using is that glossy paper, possible. Then driving at night, sunny days. So these are the measurements in the clinic will not correlate with their activities such as these. And even in simulated conditions also. So like reading, face recognition, they have less impact on the visual acuity. But there are larger impacts on contrast sensory, either with or without glare. Now, despite good visual acuity, they'll have difficulty with low lighting levels, both in stereopsis, glare, low contrast. And this has been shown in the literature. Now, what does this glare, disability glare, and all of us experience this on a day-to-day basis. It's like a veil that is thrown over a person's face. And when there's a strong light source. And these are, like I said, there are imperfections in the optical media. You can have both forward light scatter, you can have backward light scatter. And all these principles of Rayleigh light scattering, you can have May light scattering. And 3/4 of the contributions to the scattered light is from the cornea and the lens. We know this, right? Retina contributes only about 20%. So anything that happens in the front of the eye, which is cornea and retina lens, that will cause the disability glare. And you can have and it impacts the contrast sensitivity also, right? Now, how do you test for glare, right? Very simple you can do. You can have a pen torch, which is very simple. Everybody can use a pen torch. That is the most accessible. So you can have a patient read the visual acuity chart, both in the presence of a glare source and then without the glare source. You can use the pen torch. That's not ideal, but the least minimum possible. And then but what is the problem is, it's a rapid test, but you have to standardize the distance, the angle of the torch. That's why it is not very reproducible. Then you have, so basically what you're trying to do is you're assessing the visual acuity both in the presence and in the absence of the light source. Now, actually, there is no widely acceptable test for glare. And there are these questionnaires that assess these. Again, they are poor predictors of glare symptoms. Now you have something called, at least until now, we've had the brightness acuity tester, which is the BAT. Again, it is cheap. And what it does is, you can see that the picture on the right top. So you see that it uses either the Pelly-Robson charts or the Regan charts. And it's used widely, especially so you'll see after YAG laser capsulotomy, after a neodymium YAG laser. And again, but there's a nice correlation of this BAT, the measurements with BAT with the visual functions. Again, it is low cost, but the only downside is the validity is very questionable. And you can simulate any of these conditions. Like high, you can have, it is simulating direct overhead sunlight, which is 10,000 foot candles. Medium, you can have 342 candles. So something like this. So it can simulate any of these. Then you have this glare tester, which is the Miller-Nadler. I'm not sure if this is available anymore, but then again, the same principle is the same. And then you have the Vistec, the Dayton, Ohio Vistec contrast test charts. Again, this is so it has these, you can see the sine wave gratings, right? So there are 5 rows, there are 9 columns, and then it comes within a portable unit. Again, it lacks validity, it is difficult to use. Then came the stray meter, or which is the Sequant, which is the later version. Now, what happens is it directs a forward light scatter into the eye. Here, the patient controls the reference light. And so it is repeatable, it is sensitive, and it seems it is correlated with the questionnaire for glare-related issues. So this is something that people have been advocating. Now, glare is very condition dependent. And so like I said, glare happens only when there's a source, right? And so the problem is, if you neglect this and if you overlook this, this is one of the causes for the road traffic accidents that you see, because there's a strong association between glare tests and road traffic accidents. So the test that we use for visual acuity, that has very limited information, that provides very limited information about a person's performance in everyday tasks. So a very poor predictor of driving in the glare conditions, in night, on sunny days, in the daytime. So that is why glare testing is so important, because then you justify as to why that patient requires, let's say, a cataract surgery, regardless of what the high contrast visual acuity, which is what we assess in the clinics. But again, they've shown a weak association between glare test and self-reported driving disability, which means that patients do not even realize that they're having a problem with the driving when they report by themselves, because there is very poor association. And so it is very important, because ideally it seems that for driving license, they should do a glare test, but there is no suitable test. And in early cataract, that is where it plays a very important role, because the visual acuity and the contrast sensitivity will remain unaffected, but glare will be affected. So that is where you're justified to suggest a cataract surgery. So you can see this, right? The recommended road values for road light levels range from 0.5 to 2 candela per meter square. But what did they find? It falls around 1 candela per meter square. Even in US, they say that the levels are between 0.3 to 1.2 are recommended. But actually, what do they find? 0.7 to 0.013. So if that is the kind of luminance that is there on the roads, so look at the road traffic accidents, the vehicle crashes that you will find, right? And low beam intensities that are there in the car headlights, right? Car or whatever, those two-wheelers also. So if it is there, if it is the stray light that is there in the lower part of the interval, it does not suffer a large effect on their state of adaptation. So that is why that sensitization becomes an important issue. And so why is it important? Why are we talking about it? Like I said, you can have, we all know this, these days, excellent outcomes post-cataract surgery. because the thresholds for cataract surgery have dropped significantly, right? And so that is why there is a drive for measurement of broader aspects of visual. If you just keep recording visual acuity, that will be a very poor indicator for both post-operative and pre-operative criteria for cataract surgery. So, and that too, because your thresholds for cataract surgery have dropped, patients with moderate vision impairment, they will not accept good post-operative visual acuity if they keep experiencing glare and if there is loss of contrast sensitivity. And more importantly, in refractive surgery. After PRK, you'll see that corneal haze. Again, they'll have halos. They'll go on complaining of disability, glare. So that is something there, because those patients are having normal vision, right? And the moment post-operatively they start experiencing disability, glare, halos, they are complaining bitterly, and they are the most dissatisfied patients. And they are young, so they have a very active lifestyle. So same thing with LASIK also. So it seems in a survey of ophthalmologists in the UK, they showed that most people don't use tests other than visual acuity, which is not surprising. But in the US, close to about 2/3 use cataract surgeons use glare tests. So that is the difference they found between the two regions. Now, in a study in India also, they induced glare testing. This is from Kerala, and it was published during the COVID time in 2020. And they showed that you can see here, see this. So the group 1 is nuclear sclerosis, group 2 is posterior subcapsular cataract, and group 3 is a combination of that. And you can see here, you see the second, so the logmar vision. So logmar is higher is worse, okay? And lower is 0 is 6/6. So if you see here, you see the logmar values. You see in high glare, in the first one, if you see if somebody has nuclear sclerosis, it's 0.35, okay? But when it goes in high glare, you see it is 0.51. It reduced. You look at the contrast sensitivity is 1.11. And the moment it is contrast sensitive in high glare, it becomes 0.61. So look at the sudden drop. It's just nuclear sclerosis, okay? And if you see a combination also, the third group also, it's the same. The trend is the same everywhere, right? Post-operatively also, if you see, you look in group 1, post-operatively, look at that, the post-op visual acuity is 0.08. But look at the vision in high glare, it is 0.11, which means this is about close to 0.1, so 6/9. So look at that, right? So it is dropped. And if you look at the contrast sensitivity also, it has dropped. So it is so important to have this measurement, because you are able to explain the symptoms, the complaints to the patient. They are more reassured. Otherwise, they are going from pillar to post and being referred to psychologists. And the same thing here, whatever I showed just now. So you see the significant difference in logmar acuity when there is a glare as a symptom in one group, which is the left side, and when it is absent. You look at the difference, significant differences there in the logmar vision, both in high glare, low glare, all these, there's a difference in the vision, both in high glare, low glare, when there is a glare as a symptom, which is reported at presentation, and when it is absent. So the presence of either cortical riders or posterior subcapsular cataract is shown to have the associated risk of glare with the presence of, compared to just the presence of posterior subcapsular cataract, there is a 5-fold risk association. And so that is the importance of assessing by using LOX grading you can do to assess the type of cataract, right? And so the correlation that is there. So it is 5-fold increase in the glare when there are cortical riders. Now, so that is glare. Now this contrast sensitivity. What is contrast sensitivity? It is the ability to, you can see on the slide on the right, you can see this tie against a black background, and you can see the tie against a gray background. So it is the ability to detect subtle differences in luminance between the adjacent surfaces. And it's important because for safe driving, ability to perform daily tasks. And it is normal for contrast sensitivity to decrease. It decreases as you grow old, from young adult to old age. And the decrease is in the range of 0.3 to 0.6 log units. And it is because of the changes in the retinal structure and the optics. Now, what is contrast threshold? It is the reciprocal of contrast sensitivity. So it is the smallest difference in the brightness that can be distinguished. And what is the units? It is in log units. So like I said, so contrast, so there's two types of contrast, Weber contrast and Michelson contrast, you will see. In Weber contrast, it is the denominator is the luminance of the background. And in Michelson contrast, it is the average of the maximum and the luminance. Weber contrast is used when you have letters in the chart. So that is Weber contrast. Michelson contrast is when you have gratings in the chart for assessment. So you can see this nice inverted U-shaped contrast sensitivity function curve. And you can see that the contrast drops off at both the ends, and it peaks in the center. So it peaks at about 2 to 4 cycles per degree. So this is the normal contrast sensitivity function curve. Okay. Now, what are the various charts that are there to assess contrast sensitivity? You have grating charts. So they had these Arden plates. They are not used anymore. Then you had these Cambridge gratings. Again, these are square wave gratings. And again, not very, not practical. Guessing is possible. But over a few years ago, about I think 2-3 decades ago, you had this Vistec chart. Now it is not, so you'll see again these gratings, right? And this is the decrease in contrast is not uniform. Then they had this functional contrast sense, which is FACT. It's a modified Vistec again. You can see here. And again, there's a smaller decrease between each contrast level, but the test-retest reliability is poor. Now you have, I think, again, few years ago, it's a vector vision. Again, it is like a unit that is encased in this, and you'll have these two glare sources. And then again, the same thing. It's a distance gridding chart, retroillumination, and 4 frequencies are tested from 0.5 to 7%, but there is a 50% chance of guessing. Again, there is a glare source there. Now this gives you a snapshot of comparison of all the charts that are used. So we'll go to this Pelly-Robson, and then we'll come back to that. So then you have Regan charts. Now again, you can they lack equal spacing between letters. Again, not very popular. What is popular is, and what you should understand is the Pelly-Robson charts. Now you can see the chart on the right side. So it has Sloan letters, 16 groups of 3 letters each. So it's a triplet. And the contrast varies from top left to all the way to the right bottom. And the size of the octotype is constant. It's just the contrast that varies. For each triplet, the contrast is different. And it measures in the region of 1 cycle per degree, and it is done at 1 meter distance. So this is for distance. The contrast decreases every triplet by 0.15 log units. And when the patient is asked to read, they should get 2 of the 3 letters correct to give credit for that particular triplet. And that contrast, it measures all the way from 100% to 0.56. It is quick, reliable, easy to understand. The only downside of it is because it's a printed chart, the print fades very quickly. There's reflection from the surface. And then you need somebody who is literate enough, right? They should be knowing their alphabets. And then unevenness of the illumination. So nowadays they have the electronic version, which generates but higher contrast threshold. So if you compare and if you put this in perspective, you see that there's something called MARS. We'll go to that also, and then I'll come. So you have this MARS test, which is the medication adherence report scale. Now you see this, this is the MARS chart, okay? And as you can see, it is for near. So you have both numbers and alphabets. So the contrast here decreases by 0.04 log units for adjacent letters, and it is done for near. The contrast it measures is all the way from 91% to 1.2%. It is portable, so that is why it makes it attractive. People like it because it's something which is, the Pelly-Robson chart is very big, but this is portable, it's small, and it is used for near 40 or 50 centimeters. And these days you have something called computer-based testing, and the FRACT, the Freeburg vision test. Again, it uses a staircase strategy. Bracketing is done, and it is marketed by Precision Vision. They also have a free app which can be used on a CRT monitor, and it is developed by Michael Back all the way from, I think, early 80s until the recent version. So there have been lots of versions that have come up. And so before I go, I thought I'll show this table. So if you see this table here, where everything is compared, you see that Mars has the largest range, okay? And nowadays you have something called Metropsis toolbox, which is what we have at LVPEI Eye Institute also. So you can see here. So you have this console, this box in which the patient can, and they can put a chin rest. So there's a glare source on top. You see that's optional. And the examiner can look at this screen here and see what is being projected. It is marketed by Cambridge Research Systems. So it's a complete suite. It assesses various visual functions. Contrast sensitivity is one of those. And it can be used for children as young as 5-year-old. So you can see this here. So this is how the screen looks. That is the examiner, and these are the gratings that are projected. And you can see the output here on the left side, you see. So it'll give you this threshold, it'll give you the CSF. In children, you have hiding heady cards. So you see these puppet faces. Again, the contrast varies, right? I think it goes all the way to 2.5%. It is useful all the way from birth to 18%, 18 months. And you have either they are called hiding heady, happy face contrast test. You can have Lee symbols also, which is on the right bottom. Its various versions are available. Again, this can be used for children who are 3 years and older. Now, the deficits in contrast sensitivity, there's this nice paper which if you want to read, you can see they've shown how the relationship between acuity and contrast sensitivity varies in any ocular disorder. So you can see on this chart also, you see when there's normal, you see the contrast sensitivity, how high it is. And the moment there is cataract or there is age-related macular degeneration, RP, glaucoma, you see how the variation. So there is a decrease. And this is known. Any ocular disorder, most ocular disorders cause a decrease in the contrast sensitivity. You can see this here also. Same thing that, like I said. And even in early stages of glaucoma, there is a problem with the contrast sensitivity, and that explains. So people are bitterly complaining about having difficulty in performing day-to-day activities, reading faded printouts, bills. Most common are bills, are electricity bills, gas bills. They are very faded. People have difficulty in reading that. So this is my last slide there. So you see this paper that was published 3-4 years ago. They did this contrast sensitivity assessment in children both with and without ROP. So they use the newborn contrast cards in children weighing less than 200 grams of birth. And you can see that. So when there is no ROP, you look at the contrast sensitivity is high. And the moment there is ROP, you can see this examiner doing contrast sensitivity testing in the NICU unit. So look at that. So that is the beauty of assessing contrast sensitivity even in an NICU unit. And so what did they say? They said that these cards, see, you can see this. It's a viable tool to assess contrast in preterm infants. And they assured that the association, so contrast threshold itself may be an important, you can use it as one of the biomarkers. It can be used as an outcome in prematurely born infants. And so thank you very much. I hope I've completed on time. Oh, yeah, 2 minutes. So I am
Yes,
done.
ma'am, that was wonderful.
It was just, I had to rush through because I wanted to finish also on time. This is the maximum we could do because given the kind of time, these are huge, like Vijay said, these are huge topics and they would take just use a lot of time. So it's very difficult to compress something like this. I hope we've done justice.
It was wonderful, ma'am. I would request Dr. Pratisha to take over.
And Vijay's talk was wonderful. It was very, very nice. Nice
Yes.
job, Vijay. Beautiful.
Thank you. Thank you, ma'am. Thank you.
Thank you, ma'am. Thank you, sir, for the beautiful talk. Shafi, do we have any questions?
We
Yes,
had time for questions. That is the first thing. I had to rush through.
there's one question came, ma'am. How to verify, sir, it's for you. How to verify a progressive lens on a lensometer?
Okay, so I did not cover for two reasons. One, the time, but very simple. It's when you get a progressive lens, along with the lens, you get a progressive lens marking chart. Okay, so that's a very mandatory. Okay, so once you get a lens, on the lens you get the permanent markings. Okay, so that will be horizontal located. It's mostly kind of circular markings. Okay, just mark them on the lens. Okay, so then take this lens to the lens chart. Okay, put it on that and it will find the distance circle. So you need to locate the distance circle. So this distance circle should be placed on the lensometer. So then you get a spherical or whatever the power. Anywhere apart from that circle, the power is not going to be accurate. So only at that point you need to measure. So sometimes what the people do it is they don't have this chart, then they try to put it approximate location. It's not going to work out. Okay, so it's not going to be the same, but you get some power, but it's not accurate. So always you need to find the distance circle. On the distance circle, you should measure it. But thanks for the question. So
I have a question, Vijay. Then
yeah,
in the clinics we don't have that chart, no? Then how?
the people are just
So it is
it's not
wrong.
the
Okay,
because
no wonder we get it wrong then.
yeah, it's the above distance circle you don't go wrong too much. The below distance circle is the problem. So what I do is if I don't get it, I know this distance circle, I go a little even before above. So above the power is not going to change. The below power is going to change. So but ideally you should have distance circle. So otherwise you should not measure it technically.
So that chart should be made available na, in the clinics.
Every clinic you should have it.
But
Otherwise you don't.
why the optical outlet is not giving? They should tomorrow itself I'll tell you. Only then we will ask because
So that's
99% of patients that walk in are using only PALs these days.
yes.
Right. So if you don't have it, then so this is something that everybody should know.
And the tilt also will give a significant error compared to spherical lenses. So the
Right.
tilt.
So
Some people what they do, they don't attach the lens to the lens stop. Usually what I do is I attach to it. I don't hold it in my hand. Moment you hold it, you give a tight kind of tilt. So you don't hold the lens. It has to be held by the lensometer itself, not by you.
Good. That was a nice question.
Yeah.
People are attentive.
Yeah, that's I'm happy.
I like this. Nice.
Ma'am, there's one question for you as well. How do optical aberrations shift the contrast sensitivity function, or like how it affects?
Correct. So you'll have these aberrations the moment, usually after refractive surgery. Okay. And both higher order aberrations will be there. We know this. And so what will happen is, I think usually it is the middle spatial frequency that is not usually affected. And I think even in cataract surgery, probably, so the high spatial frequency is the visual acuity usually. So that matches with the visual acuity. It is the probably the middle and the lower end that gets affected then.
Okay.
Especially the middle. So for face recognition, it is the middle spatial frequency, middle to low, which is important. And that is where patients with vision impairment or little changes in contrast, that is the first complaint that they will say. And so think of it, on a cloudy day, you have difficulty seeing through, right? Foggy day. So that is what is loss of contrast sensitivity. And driving becomes the major because all our, what is it? Speed breakers, they are not in a different color, right? Compared to the road. So they have to be painted either yellow or white. And that is where you have most of the vehicle crashes happening there because of the contrast sensitivity. So they say that for driving license, contrast sensitivity should be assessed. Glare should be assessed. But so this is not done even the most developed parts of the world. So, but that's a recommendation. And every clinic, according to me, who is doing any of these cataract surgeries or anterior segment, this refractive surgery, should have assessments of glare and contrast sensitivity. You cannot get away without that because your patients will be demanding going forward for sure, because you're doing it on close to normal eyes, so that they'll be very demanding. So it's just to make sure that your patient understands that you understand your subject, just to convince them. Otherwise they'll go window shopping. So I think
I also have a question, like, especially for the patients going for premium IOLs,
yes.
do you practice measuring their contrast sensitivity in pre-op?
No, here we don't do it now. But my recommendation is that I've been saying this for almost 40 years now. I said this when I joined, and I'm saying this today also, that you cannot get away without assessment of contrast sensitivity. Yeah, in let's say in severe vision impairment, all of that, that's meaningless because there is a high correlation between impaired contrast sensitivity and visual acuity. So that is senseless. But you want to do it when, like I said, when there is mild vision impairment, right? When your visual acuity, your patient's complaints are out of proportion to your visual acuity, right? And they are bitterly complaining. And one dissatisfied patient is enough to ruin something.
Yeah, ma'am, same thing. I want to reinforce your point here. When the patient come for cataract surgery, most of the patient in India, they have cataract nucleus sclerosis more than 3 or 4. So contrast sensitivity will be definitely be affected. So the point of doing contrast sensitivity, especially in cataract patient, is post-surgery as well, not
Negative.
only the pre-surgery. Second thing, I want to add that when I practice cornea, so a lot of keratoconus patients. So before I do any collagen cross-linking or any other treatment, I try to do contrast for all the patient, and it makes more sense when you're doing the refractive surgery for the young people. Then we have to assess contrast sensitive before procedure. So these procedure make a lot of sense if we do that.
What chart do you use?
Ma'am, we have Pelly Robinson, which is like a basic test we are doing because
Robson.
yeah, so but Pelly Robinson, yeah. So but other thing is that because we are doing it in the normal refractive patients, I like to chart my this how after procedure, how fast they accept the contrast in the back, they get the contrast back. So that's why I do that. But mostly in cataract patient, even if they're premium lenses, they're grade 3, grade 4. Contrast is not that great even if we do that surgery before surgery. Yeah.
So that's what. So these days, like I said in my last slide, they have that Metropsis that is from Cambridge Research Systems. So it is marketed by them, and it's a complete unit which assesses different visual functions. You have color vision, you have contrast, you have everything in that, and so that is something. And so that is something. I think it's from Europe that they are marketing, Europe or US, but. That's a nice, I think that's very complete, and it's fancy, it looks nice. The only downside with this Robson, like I said, because it's a printed chart, no, it is very difficult to maintain it, and not even a year. And unless you use gloves and all, not even a year, they fade very fast. Normally cited, normal, you can't read that chart after 1 year. So it becomes very difficult. It's very unfair to use it after that. So it requires frequent replacement. It's
Yeah.
expensive. I think it's in the range of close to $500 to $600 from, if I'm not wrong.
Uh-huh.
So it's expensive, and so people don't replace, and then they have, and then the problem is again the assessments are not, it's not over a wide range. It's a not a very wide range, so you get pretty narrow values, and so that's why I think it is very limiting that way. But having said all of that, in what if you're compared to not doing something, assessing is great. So I'm all for assessment.
It should be the standard of care.
Yes.
Yeah.
And glare also.
Yes, yes, definitely, ma'am. Would you like to add anything, Dr. Pratiksha, or should we call it a day?
Mulika ma'am, if we find like the contrast sensitivity is impaired, especially in the premium IL patient, what can we do in such patients in post-ops?
There's no answer to that question.
Oh, hang on.
Depend.
No, no, no.
Depend.
No, no, one
Yeah,
minute,
Dr.
one minute.
Vijaya will add
Yes,
her
yes.
points on that. Yeah.
So, so depends on what they're complaining about. Okay. So they say face recognition. Now you cannot do anything about that. It's not an infant who is complaining. Obviously, this is somebody who is 50 plus, 60 plus who is complaining. Okay. Now face recognition. And the face is the worst contrast because the graduation is not very, means the difference is not there, right? So that's why face recognition. So you tell them, look, you use overhead reading lamp with tube light. The contrast has to be good. Then this, they say, this tablecloth or means that the way you lay the table, that cloth, and that table mat should be a different color. Otherwise, and then the worst part is the floor tiles and that flooring, right? That is where, and then the steps. They have difficulty negotiating stairs because they topple over. They can easily fall. So you tell them, look, use railings. Please make sure, because fall in older adults because of impaired contrast sensitivity is common, and they don't attribute that to vision, right? And one is use of bifocals, two is impaired contrast sensitivity. These two are factors that have been shown to have result in falls in, and then they end up with a fall, knee issues, and then they are bedridden, and then there's a vicious cycle. So it can be that dangerous. So it is important. So, and now the at home stairs negotiating is not a problem, right? It's only outdoors. Now that's not controllable. You can't control. You can't put a means that strips or that edge of the stairs, you can't paint them in a different color. Ideally, that is how it should be. But then if in your clinic or in your hospital, that can be done. So you can paint the edges with a contrast color. You can have a strip or something like that so that it's highlighted where the next step is, or they can again use hand railing. So if you counsel your patients this way, they are reassured, and then they can take preventive measures so that they don't fall. And fall is the worst thing that can happen because of a cataract surgery.
Ma'am, the point well taken. But there was one small point what Pratiksha pointed out, that if they have a premium lenses, which they paid a lot, and then if they have a bad contrast, then it is a big deal for them, of course. So we don't put premium lenses in such patients where the visual prognosis is bad. But so many patients come with those kind of lenses where the visual prognosis patients are not happy. So in such cases, I don't know, we can take these measures, but the lenses are there, so they are always asking about that, such a costly lens, but my vision is not good. So that was the problem. Yeah.
Yeah, good pre-op assessment is very
Yeah.
important, right? So if you do not do a good pre-op assessment, that is where you land in trouble. So I would do a good pre-op assessment to know if this patient is an ideal candidate for a pre-MM IOL. So the problem with all of this is the lack of attention to all these details pre-operatively. So in that hurry, these details get missed.
Definitely, ma'am, definitely, you're totally right. I totally agree with you. Yeah.
Yeah. See, having seen the evolution of cataract surgery over the last 40 years that I have seen, this is the trend now. And I'm going on saying this, right? Patients are not going to accept this, and they are coming to you in the range of 6'9", 6'6", and they're already 6'9", 6'6", right? And any little bothersome glare, contrast issues, they will create a ruckus.
Yes,
So
of
I
course.
think you got to shield yourself and make sure that you selected the right patient, and whether it is trifocal or whatever it is, whichever extended depth focus lenses. So you got to make sure that, and monofocal. So if they are not driving, then probably just a monofocal is enough, not a multifocal, things like that. So I think pre-op counseling, spending some time with the patient, they understand. The problem is when that communication is not there. That is where you have a dissatisfied patient. But once you have communicated with them, they understand that you have spoken with them, you understood them, then I think they understand. They also understand. So I think it is just that communication channel that has to be kept open, so that they know that you understand their problems. So it's all about communication. So power of communication.
Absolutely correct, ma'am. Dr. Vijay and Dr. Vijaya, your energies are infectious, and we would really thank you to coming over. And I would tell to all my audience here that they can post their question to any platform, and we would like to answer those questions. We'll try our best to answer this question. Then they can be in contact with us anytime they want.
Sure.
Thank you very much, ma'am.
Thank you.
Pleasure, yeah.
Thank you.
Thank you,
Pleasure
ma'am.
being
Thank you,
here
sir.
and talking.
Thank you so much.
Sir.
Bye.
Bye. Thank you, ma'am.